I want to welcome you all to the Rural Opioid Prescriber Training provided by the SIU School of Medicine and Illinois Department of Human Services, Division of Substance Use Prevention and Recovery, with funding through a grant from the Substance Abuse and Mental Health Services Administration. After today's presentation, we will discuss how your healthcare organization can apply for a $10,000 grant for implementing medication-assisted recovery services. Today's topic is addressing barriers and implementing treatment for opioid use disorder in clinical practice and will be presented by Dr. Kate Austman. Dr. Austman grew up in a small town just outside of Peoria, Illinois. She attended St. Louis University, where she earned her Bachelor's of Science degree in psychology in 1994. She then worked for the American Red Cross for 3 years. After that, she attended the University of Illinois, Chicago, earning her medical degree and completing a family medicine residency in 2004. Dr. Austman then went to work at the Gibson Area Hospital and Health Services as a family medicine physician with obstetrics. After 15 years as a family practitioner and obstetrician, she found the need for substance use treatment to be great in her rural community and pursued a fellowship in addiction medicine with St. Louis University School of Medicine. After her fellowship, she has continued with the Gibson Area Hospital as an addiction and family medicine physician. Dr. Austman is a faculty member with University of Illinois College, where she is the rural lead for training family medicine residents. She is also a faculty member with St. Louis University in the Addiction Medicine Fellowship, where her role includes teaching family medicine residents as well as addiction medicine fellows. She has a passion for family medicine and a keen interest in the full spectrum of care, from newborn to the geriatric patient. Dr. Austman is married to Jeff, who farms full-time. In her free time, she tries to keep up with her 3 children and enjoys outdoor activities such as running and cycling. And I will turn it over to you, Dr. Austman.
Thank you. Good afternoon, everyone. I hope you are staying safe in this. We have a lot of wind right now. I am going to share my screen here. And good. So we jumped right to, okay. So I don't have any disclosures. Today I'm going to talk about how to start treating patients with opioid use disorder in a clinical practice. I am in a rural setting, as we talked about earlier, and I have, kind of came to this after seeing patients in my office that were suffering with this, and really was frustrated because I hadn't gotten a lot of education about this in medical school or residency. And so I needed to educate myself and then helping others to learn this as well. So I'm not going to go through a bunch of slides at this point about the opioid epidemic, because probably most of you have heard this. You've already seen the statistics. You've already seen all of the reports about the overdose deaths and things like that. We do know that opioid use disorder is a problematic pattern of opioid use that leads to serious impairment or distress. And the 12 months ending June 30th of 2021, we saw over 100,000 overdose deaths in the United States, and that was mostly from opioids. And we know that substance use disorder it's a disease requiring compassion, ethical, equitable, and evidence-based care. So when we think about caring for patients with opioid use disorder, where do we care for these patients at? They can be cared for in the emergency department, primary care clinics, outpatient treatment programs, or a methadone clinic. They could be cared for in the hospital, in a residential facility. But I think oftentimes it really feels like this care is being carved out. And why don't we care for these patients in our primary care practices? And I kind of want to go through that for a minute about why there is such a barrier for this, right? So mostly we're going to be talking about buprenorphine or Suboxone treatment. And why does it feel uncomfortable for a lot of providers to look at this and say, yes, I can do this for patients? Because when we graduate from medical school, or if you are a nurse practitioner or physician assistant, as soon as you get your DEA, you are allowed to prescribe medications such as warfarin or insulin or fentanyl, right? These are medications that actually carry quite a bit of risk, and buprenorphine doesn't. So what is the barrier? Why do we have a hard time with this? So I'm going to go through a little bit of history to sort of guide us through what some of this is about and how we got to this place. So we're going back 100 years here. Hang with me. I promise this will you probably will find this fairly interesting. I did. So in 1914, prior to 1914, anyone could buy cocaine or opioids, specifically heroin, on the street. It was legal. You could buy that. We know that that Coca-Cola had a little bit of cocaine in it. You could buy a tincture of opium from your pharmacist. But in 1914, the Harrison Anti-Narcotic Act was a federal law put into place. And it stated that only pharmacists and physicians, they were the gatekeepers for the distribution of heroin and cocaine specifically. And then through a series of laws or court cases after that, specifically in 1919, Webb versus the United States, these came down saying that for a physician to maintain a person who was addicted to an opioid, for the physician to maintain that person on an opioid was not good faith medical practice under the Harrison Narcotic Act, and therefore it was an indictable offense. So this meant that physicians could lose their license, they could be incarcerated if they prescribed opioids to someone with an opioid use disorder. So the responsibility for treating these types of addictions went from being, the responsibility for care went from being a medical problem to really being a criminal justice problem. And so from the 1920s on, then, this was really where we were in the United States. And physicians were actively discouraged from treating people with addiction, and especially heroin addiction. So medical schools didn't address this because there was this threat of criminal justice or this threat of incarceration and losing your license. And then we forward to the 1970s. So in 1972, methadone regulations came through, and in 1974, the Narcotic Addict Treatment Act. Basically, these said that physicians could prescribe this, but it had to be in a closed loop system. So this is where the methadone clinics started. So it all had to be prescribed and dispensed from the methadone clinic if it was to treat opioid use disorder. Now, most of us know you can write methadone for chronic pain. Anybody can write that from their office. I don't generally recommend that. It's not a great medication for chronic pain, but we can go into that. It's a little bit of a different discussion. So again, it sort of emphasized the fact that, this is why a lot of physicians weren't exposed to this. We didn't have experience with it, and it made us very uncomfortable to think about this. So then we fast forward again to 2000. In October of 2000, something came through called the Children's Health Act of 2000. And within this act was the Narcotic Addict Treatment Act. And what it said is that providers could start writing medications that were Schedule 3, 4, or 5 that were approved by the FDA for opioid use disorder. Now, we didn't have one yet that was approved. And so by 2002, in the fall of 2002, October 3rd, is when buprenorphine became available. So buprenorphine and buprenorphine plus naloxone. But that's where this Data 2000 or your X waiver comes in. So physicians have to go through the extra training, and they have to get, also nurse practitioners and physician assistants. So we have to go through this. We have to go through these extra hoops, not because buprenorphine is dangerous, not because of its street value, things like that, but because we have to get around this federal law from 108 years ago in order to be able to prescribe buprenorphine. So I think when we look at it, and when administrators or people who are in charge of clinics are looking at this and kind of worrying about, do we really want our providers doing this in clinic? I think this is a compelling reason why we do want it done in clinic, that this is part of their healthcare and it should be done in a clinical practice. Okay, enough of a history lesson for now. We'll move on with the show here. Maybe we will. Sorry, if I can get my, perfect. So what do we want to think about if we want to start treating patients with opioid use disorder in our clinics? And a lot of the information that I'm going to be going through today, it's probably going to feel a little bit like drinking from a fire hydrant, and try not to feel overwhelmed. Really, just thinking about starting the process is a really important step. But we want to start thinking about team-based care. So who's going to be providing the care for the patient? Who's going to be your nurses involved? Who's going to be your medical assistant? Who's going to be the front desk person taking the triage calls? We think about creating clear referral processes, setting protocols. So you already have protocols for when other patients call in. You can do this the same way for persons with opioid use disorder. Creating patient-client agreements, or I'm sorry, patient-clinic agreements. And a lot of these can be found. A lot of the stuff that I talk about in here, I will give you some resources towards the end of the talk that you don't have to reinvent the wheel. This information is already out there and you can use it. You want to think about drug testing, and we want to think about mentorship as well. So again, who's going to be on the team when this is starting? Is it just going to be the provider? Do they maybe just want to start with 1 or 2 patients and go from there? But if you're hoping to make a bigger team out of this, who will be on that? So like I said, your nurses, your office assistants, which providers are going to be involved. Maybe there's a case manager or a nurse care manager. Then also looking at who you have in your system who might benefit from this service line. Hopefully, most of you are doing a substance use screening. I do one every year. On all my patients, even on our teenagers. So for the teenagers, we use the CRAFT screen. For my adults, I use the NIDA screen. But trying to have some sort of screening in place that you might be able to identify patients that you would not have otherwise known were struggling with this. The other thing that you can do too is have signs up. We have signs up in my clinic. We have signs up in the hospital that just say, are you struggling with addiction? Do you need help? Here's a number to call. So it can be a little bit more anonymous that way. So you're not asking the question, but maybe their family member sees the sign, or maybe the patients themselves see the sign and say, yeah, I'm ready to seek help. Then also, who's going to be reviewing the drug screens, the counseling reports? Setting some time out to discuss challenging cases. So you may be doing this already with other patients, such as your diabetic patients, or if you provide OB care. We do this. So I still provide OB care, and we don't have a formal team huddle every week for OB care, but we are constantly discussing these patients and kind of what we need to do going forward. And we do that the same with our addiction patients as well. And then plan of care for the following week. So especially this time of year when you may not be able to be in clinic. So we've got another code white coming up tomorrow, potentially, where the clinic might be closed. So if those patients are on the schedule that day, what are you going to do? Are you going to convert them to a telehealth? Are you going to just talk to them over the phone? Things like that. So when we think about workflow, who can refer those patients either to you, or if you want to refer them to someone else? Can it be another primary care provider that's referring? Can they be just self-referred from the patients that are already in your clinic? Maybe there's outside entities. So if they are being discharged from a residential treatment, if they're being discharged from inpatient, maybe mental health or other inpatient, they had a motor vehicle accident and it was discovered that they also had opioid use disorder, are you able to take those patients in your clinic? And also persons who are involved with the criminal justice system. Are these patients that you are able to see and able to work with? And sometimes that is, kind of a hard ask, and it's a little bit tough to do. So just thinking about what you have the capacity for and what you might want to bump on to someone else who's able to do that. And then how do you want the patients to be scheduled? I think this is a little bit of a tricky one, because when I think about a new addiction patient for me, it takes me probably a good hour to get all the information that I want. But sometimes I don't have an hour in my schedule if they call in today and need an appointment, or if and the patient may not have an hour either. Oftentimes, they might have a ride who's waiting outside. So sometimes just getting them in, getting at least the preliminary things done, and then catching up later. And we'll talk a little bit more about that too, as we talk about the history and physical and things like that. But kind of figuring out how are these patients going to be scheduled? Do you have a triage form at the front desk that someone's filling out and then addressing with yourself or the staff? Here's just an example of a workflow for what this can look like. And again, for a primary care clinic, this probably doesn't look a whole lot different than what you would do for most patients, right? So if we look at the right side of the workflow, if a patient walks into your clinic, are they safe? Do they need care immediately? So is there somebody to triage that can say, yes, they can sit and wait for the next spot that opens up, or no, they need to go to the emergency room or to an urgent care clinic? Again, I am in a pretty rural area. And so if we're able to see patients that day, we do, because we don't have urgent care clinics to send them to. Our emergency room is right across the street, but oftentimes they don't need emergency care. And honestly, these patients, we rarely get them just walking in the door. Usually they're calling. So on the left side of the flow chart, what happens if they call in? Is it a family member, a friend, or someone else? If it is, I really encourage them to have the patient call themselves. I think it goes better. I think we get more information, and we know that they are ready. So sometimes a family member really wants the patient to get into treatment and the patient isn't ready themselves. And so I think if they are able to call and make contact with us, it just works better. But you can, do it however you want, honestly. What if it's coming from a treatment center or another medical professional who's going to be taking those calls? And then if it's a call from a patient talks about filling out a referral form. So I talked about my OB patients. We have a triage form for OB patients that call in. We have a very similar triage form for patients that are calling in with substance use disorder. And we tweak that. I mean, every few months, I think I'd like to do that a little bit different. And we fill that out differently. So it might be my front desk person taking the phone call. It might be the case manager taking the phone call. It might be the nurse. So it just kind of depends. We don't have a really large office, so sort of everybody answers the phones. If the front desk person is on the phone, then other people might be answering it. So everybody's sort of aware of where these forms are and how they need to be filled out. Okay, so initial assessment checklist. So you're seeing the patient for the first time. Who does the initial assessment? And every provider does this differently. So sometimes providers have their medical assistants or CNAs rooming the patient. Maybe it's a nurse, maybe it's the provider doing the entire thing. And any of those ways are the right way, whatever works best for you. So things that you might do when they initially come in. Maybe you have an intake questionnaire. If the patient has time, if you have time, if they can fill out, again, the NIDA screen, because just because they're coming in for opioid use disorder doesn't mean that they may not be struggling with other substances as well. So screening for those other substances, having them fill out the PHQ. We usually do a PHQ-2 initially and do a GAD-7, but some of those, social determinants of health is also a big thing for us. So there's a social determinants of health questionnaire that we give patients to see if we can assist with any of those things. Doing a history and physical. Do you want to get a urinalysis, urine drug screen, and other appropriate labs? I will emphasize to you, you do not have to have labs in order to start treatment. It's a great thing to have. It's really nice to be able to do that eventually, but sometimes your staff may not have time to do it. If it's somebody who was, kind of put into a narrow slot on your time schedule, the patient may not have time to wait. Some of these patients, if they've been using IV drugs for a long time, their veins are really kind of resistant to us drawing blood from them. So it may be something that you're not able to obtain that first visit, and that's okay. If you feel they're appropriate for starting treatment, then you start treatment. I can't think of any labs that would dissuade me from starting treatment, even pregnancy. And we can talk about that if people have questions about that. The urinalysis or the urine drug screen. So we do those. You really need to be cognizant of the fact, though, or aware of the fact that there is no point of care test that is CLIA waived that can pick up fentanyl. So, and you're probably Googling that right now. There is a company called CLIA waived that says they have a point of care test for fentanyl, and that is true. But right now in the United States, there's no CLIA waived test that's point of care for fentanyl. And the problem with that is that, and some of you who maybe are already doing this work, we're not seeing as much heroin, and we're seeing a lot of fentanyl. So a patient may come into you saying, yes, I use heroin every day. Here's how often I use it. And their drug screen is completely negative for everything. And then you're sort of like, I don't know what to do. Well, it's probably because the fentanyl is not being picked up, and you can send that off for a confirmatory test if you want to. I would not withhold treatment at that point. If the patient says they're using and they would really like to get into treatment, then that's the direction that you should take. You also want to do a PMP review. If you're going to be prescribing buprenorphine or any other opioids or any controlled substances, then checking the Illinois PMP website is what you need to do, and you need to document that in the note each time that you are prescribing. Now, you should not print out the PMP and scan it into the chart. I think that's actually not legal to do that, but you do need to review it and just document in your note that was reviewed prior to sending medications. The chart flagging and pop-up as part of your workflow, everybody's a little bit different, and everybody's electronic systems are different if you're using electronic. Release of information. So if the patient is agreeable, if they have a primary care provider, maybe they have a psychiatrist, maybe they have somebody else, or maybe they've been in other treatment programs, if they're willing to sign a release of information, that can be helpful. Then talking about the education, explanation of the program, harm reduction, medication options. Again, who in your office might do that? I actually lean pretty heavily on my nurse. I have 2 nurses, and one of them does a lot more of the addiction patients than the other one does. And she generally goes through our consent forms and kind of how the program works. She talks to them. Like once we have decided to start buprenorphine, she kind of talks them through that too. So who's going to be doing that education and the discussions with the patients? Controlled substance agreement. If you're using buprenorphine, you don't have to have that. I think it's not a bad idea. And again, there are examples of this. If you haven't looked at SAMHSA Tip 63, they've got a lot of examples. Again, you don't have to reinvent the wheel. You can take these off their website and sort of tweak them to whatever your clinic needs and make them your own. Then talking about home induction versus office induction, I don't know the last time I did an office induction. Almost everyone is home induction at this point. And I don't know that this, that this talk today necessarily needs to go into that. If we have time at the end, though, and you have questions about that, I'm certainly happy to answer those. Overdose prevention, though, is incredibly, incredibly important. So whether or not the patient is ready for treatment. So sometimes you'll have patients come in, you'll talk to them, you'll discuss all the options, you'll discuss, methadone, buprenorphine, naltrexone, and maybe they're just not ready. They're just not in a spot where they want to do that. Or maybe you're seeing them for something completely different, that they didn't come in for their opioid use disorder, and you discover through another route that they have this. You want to make sure everyone has naloxone or Narcan, either a prescription or they have it in their hands as they leave your office. It's really, really important to do that. People cannot get into recovery if they don't survive an overdose. So we really need to be able to get that naloxone out there. We need to train people on how to do that. And so it's important to talk to your patients about this. So when you are doing the intake and you're looking at getting a history on the patients, this is not any different than your history and physical from any other new patient that you might be seeing. And again, if you aren't able to get all of this information at the first visit, there's still time. You can get this later. There, just like with lab work, there's almost nothing in their medical history that would prevent me from using buprenorphine for them. It's life-saving medication. It's much better than them continuing to use illicit opioids off the street. And so if they're ready for treatment, but you don't have the complete, their complete history, that's okay. What you do want to do, though, is document their opioid use disorder, and you want to use that DSM-5 criteria. So again, that's something you can make a checklist that's really simple to do. So there's 11 criteria, and you want to be able to document that they have a moderate or severe opioid use disorder, and that's why you're prescribing the buprenorphine. So that is important. I mean, that's something that can be looked at if if an outside regulation wanted to go through your chart and look at that. So it's important to do that. And it's nice too if you can document if they're in active use, early recovery, or extended recovery. You want to know if they have a history of injection drug use. So, because they may be at increased risk for certain infectious diseases. They may be at increased risk for cellulitis with that. Treatment history. Have they ever been on medication before in the past? And again, most patients that are coming to see me have tried buprenorphine in some form, whether they've gotten it from a different clinic, whether they've been in inpatient or residential treatment before, or a lot of them are getting it from friends or buying it off the street because they wanted to start treatment on their own and just weren't able to continue doing that. And it's pretty expensive. I think, I want to say my last patient told me it was like $10 a strip. So for them to do that is really hard. So it's kind of good for us as providers that a lot of people have already tried this. They already know what they are getting into. Maybe they've already had precipitated withdrawal, and we can kind of talk them through how for them to not have that again. But what is their treatment history? What have they used before? What's their current living environment? So again, I talked about social determinants of health before. Are they someone who's experiencing homelessness? Are they, do they have others that can support them at home? Are they living with other people who are using? And that can kind of be a barrier to care for them, and can also, of course, cause some triggers to relapse. Family support and other support. So who do they have in their life that can help them? Again, what are their goals for treatment? So we use our motivational interviewing and kind of meeting the patient where they are. Do they want to be abstinent from all substances? Do they want to cut back? Where are they at in their progress? So I talked about past medical history, psych history, their medications, their allergies, surgical history. This is all stuff. If you're a provider, you know how to do this. You've done this a million times. History of employment, educational. That is useful, especially if someone is currently employed and there's a work schedule that they need to kind of navigate. It's going to be, it'd be helpful for you to know, but again, not absolute. If they're engaged in another treatment program, so maybe they are involved with the justice system and they're in a drug court, or, and of course you wouldn't be able to get a release of information for that, but it is good to know that residential outpatient or intensive outpatient, those are all nice things to know if the patient is engaged in that. Alternative phone numbers in case they can't be reached. And even with our patients who are not substance use disorder, we see this with a lot of other patients, right? Like they have a track phone that they only have so many minutes on. So do they have a family member that they can trust that we would be able to reach out to? And of course, you would want to have that written that we are allowed to call another person if we can't reach them. And sometimes they give it to us and sometimes they don't. So trying to get that information as best you can is useful. So what do we do with these labs when we first see the patient? Checking their liver function, the liver function test LFTs is helpful. Again, it's not a reason to not start medication. The general rule is that if the LFTs are less than 5 to 7 times the upper limit of normal, you're fine. I've seen them even higher, and I've talked with the gastrointestinal, my GI colleagues, and we have started buprenorphine on someone who had recently had an overdose, but also had acute hepatitis C, and so she had very high liver enzymes. We had no troubles when we started her on the buprenorphine, and her liver enzymes actually progressively decreased, and we were able to start her on medication for hepatitis C as well. Urine drug screen, I already talked about that a little bit. The urine drug screen is useful at the beginning to kind of see what else the patient is using. And sometimes they don't even know what some of their other, so maybe they're only using methamphetamine, but they come up positive for, well, it's usually not heroin, they can come up positive for fentanyl, or if they have benzodiazepines in their system and things like that. So it's useful as a guide to get started. After that, the only thing I use a urine drug screen for is to document that the patient has buprenorphine or norbuprenorphine in their urine. I do not use it as a punitive measure. I do not discharge patients from my clinic just because they continue to use other substances. I try to figure out why they might be using other substances. Is there something that we can do? But really try to not use that as a punitive thing and use it more as a therapeutic tool. Pregnancy tests when applicable. So if you have someone who could possibly be pregnant, again, not a reason to not start buprenorphine, but it is good to know if they're pregnant, and then what referrals need to be made from there. If the patient's willing, it's really important to get HIV, hepatitis C, sexually transmitted infections, and other labs as needed. So prior to treating patients with opioid use disorder, of course, I screened everybody because that's the recommendation right now, or we screened a lot for hepatitis C. So at the time, so our patients are born between 1945 and 1965, right? We were screening all these people. And then, of course, all of my OB patients would get screened. And I never had one case of hepatitis C since I was out of residency, which has been a minute. Once I started treating people who were using via IV, but also if they're insufflating or if they're snorting methamphetamine or opioids, that is also a risk for hepatitis C transmission. So I have seen many, many people, and I've actually been able to successfully treat them. So it's kind of exciting to be able to do that. And it's really important to screen these folks for that if they're willing to. So for care coordination, again, checking the PMP and documenting it in the chart. If the patient's receiving benzodiazepines, it's nice to talk to the other provider to find out why. As most of us know now, really chronic benzodiazepine use, long-term use is not really indicated for anything, but there are a lot of patients who are getting chronic or benzos. There are also a lot of them being bought off the street. So FDA released these recommendations that said that you should not withhold opioid use disorder treatment just because they're on benzodiazepines, but you do want to, counsel the patient that it can increase their risk for overdose. But it's a pretty small risk, and their risk for overdose without treatment is much greater. So this slide looks at the billing. The billing is the same as you would do for any of your other patients. This isn't there can be some unique things with addiction and some of the screening things that you're doing, but I would encourage you to talk with your biller. But as far as a primary care note goes, or when you're in the clinic, these are your same codes that you would use, whether the patient's new or established. And now, starting last year, we can base it on time. And or medical decision making. So we kind of have some flexibility with that. So the education, I talked about the overdose education and the importance of talking about harm reduction and getting naloxone into the hands of many people as we can. You can give them there is a standing order for the state of Illinois for pharmacies who choose to participate in the program, that anyone can walk into that pharmacy and receive naloxone without a prescription from a specific provider. So it's just a standing order. Now, not all pharmacies have opted into this program, but many of them have. All insurances in Illinois must pay for naloxone in some form. Most of them are paying for Narcan. I've never had one that I've not been able to have Narcan given to the patient, but some of them want the injectable, or so I've heard. I think that's kind of unusual now. And there's a lot of places that patients can get the nasal naloxone from health departments and other organizations. We've been able to get it at my clinic. We applied to the state for a program where we are able to get cases of naloxone and then be able to distribute those to the patients. So that's kind of a nice thing for our patients. Just determining insurance coverage is always kind of tough, and that's not my area of expertise, but I do try to work with the patients as best I can. The different brand name or generic formulations of buprenorphine, again, if you work with a lot of patients that have the public aid for Illinois, they cover anything as far as buprenorphine goes. They cover whatever formulation the patient wants. So whether it's Zubsolv or Suboxone or generic, whether it's strips or it's tablets, that's covered. Now, some of the private insurances, it's a little bit different. And sometimes we have to jump through some hoops if we want something other than generic. There's this bullet point here that says for pregnancy, buprenorphine only. That's actually changed over the last couple of years. And if they're already on the combination product, I wouldn't necessarily switch them off. There's lots of data coming out saying the combination product is safe in pregnancy. And sometimes you're not able to get the buprenorphine only product. Again, if you're in a small community like I am, where you might, your local pharmacy only has the combination product, they can get the mono product in, but it might take a couple days. If that patient's pregnant and ready to start, go ahead and use the combination product, and you can always switch them over to the mono product later. So this is a nice poster that you can put up. It's from the Chicago Department of Public Health, and they are very willing for people to download these and put them up in their offices. We put them in our packets that we give patients when they initially come to us. This is the back side of that flyer. Paperwork, just your treatment agreement. So what do you want? What do you want in that? And you can tailor that to whatever works best for you and for your office and for your staff. What are the expectations of the patient? Do you have a late or no-show policy? Do you have a lost prescription policy? If a patient comes to me and say that they've lost maybe they had their prescription stolen for their buprenorphine, I tell them I want to see a police report. I try not to make them go too many days without their buprenorphine. So if this is something that they start having some issues with this, and maybe we went to 2 weeks in between prescription refills, then maybe we go back to 1 week. Or if they've been going a week, maybe we go back to 3 days. So kind of what those expectations and what that looks like going forward. Coming to clinic intoxicated, ongoing substance use. Again, these are not necessarily, coming to clinic intoxicated is a little bit tough, right? So some people might, as you know, with alcohol, if there might be people who have a blood alcohol level that is much, much higher than something I could ever tolerate, and they are walking, talking fine. So I think that definition of intoxication is different for everyone, and you can kind of decide how you want to do that in your clinic. I do tell my patients that there are 2 reasons that I will fire them from my clinic. The first reason is if they are abusive physically or verbally to my staff. And the second reason is if they are diverting their buprenorphine and, I find out about that, or we have suspicion. And even then for the diversion, I may not fire them, but we may want to talk about other options for treatment for them. Maybe they need a higher level of care. Maybe they need a methadone clinic. So that's kind of how I handle those things. Then patients' expectations of the clinic. How available are you? When can they expect to get in? If they need to call and cancel, what happens? What's your flexibility on being able to change that? When can they expect to get a call? So if they're in your office today, will the nurse call them tomorrow? Will it be 3 days? And what support services do you have available for those patients? And kind of when, it might be time to refer someone out again to a higher level of care. This is that treatment agreement that I talked about from SAMHSA's tip 63. So again, you can download this, you can tweak it to make it your own and use that in your practice. This is just the second page of that. I kind of talked about the drug testing already, combining it with the patient's self-report, use it as a therapeutic tool. Yeah, I think we kind of discussed all of this. If you're not familiar with the Illinois helpline, I would encourage you to try and take a look at that over the next day or two. So there's two sides to the Illinois helpline. One side is for patients who are looking for a provider. They can look that up. And the other side is for providers who might be looking for mentorship. And so there's providers like myself that are available. So you can go in, you fill out a form. And it's not a binding contract. You might fill this out just because you'd like to be able to call somebody once in a while and say, hey, I have this kind of scenario. Can you help me through this? Or maybe you have other questions, or maybe you want to meet once a week for 20 or 30 minutes, and that's okay. There's all different levels of that. So if you haven't looked at that, I would encourage you to. Again, it's non-binding. If you decide you want to sign up for it, we're not going to bug you with a bunch of emails and come knocking on your door and figure out where you are. We want to be able to help other providers be able to start and feel comfortable with providing treatment for opioid use disorder. Okay, let's talk about counseling really quickly. We want to consider referral to outside treatment services for additional support. If you have obtained your X waiver and you've gone through if you've obtained your X waiver, so one of the things is that you say that you are willing or you are able to refer for counseling services. That doesn't mean that the patient has to accept, doesn't mean that the patient has to go, but that you have the ability to try to refer. Sometimes that's within your own clinic. So I have a social worker that works with me. It's really convenient for me. Sometimes, there's also a clinic in our community that I can refer to. During this COVID time, there's lots of patients that are doing this online, but there's also a lot of people who just don't want that, and that's okay. But you just have to be able to refer them when you applied for that X waiver. Again, all of this stuff is not new to you. It's the same thing that you do if you have a patient who's struggling with other mental health issues and patient factors to consider. So are they interested? Are they willing? And can they participate? All those types of things. So this is talking more about if your clinic for substance use treatment providers, and this is like a non-primary care clinic. So I'm going to skip over this a little bit. If people have questions on this at the end, I'm happy to go back to that. But in some of those substance use treatment programs, they generally have an end date. Well, we all know working with our patients, we sort of expect to keep them forever, right? Like they come into us, if we're primary care, then we don't have an end date for this. Again, counseling services are really useful, but they're not necessary. We know that the thing that keeps people alive with opioid use disorder is medication. So that is the thing that will reduce their risk for their chance of overdose death, is treating them with medication. I think counseling is fantastic for everyone, but it's not an absolute requirement. If you want to identify providers that are in your area, that your clinical team can reach out to those providers as well if that's something that you're needing for a patient. And that those referrals can also go both ways. So you might be referring to a treatment team that is providing the counseling or maybe some mental health services. And maybe you can open it up that telling them, hey, if you have somebody that needs treatment for opioid use disorder, we would love to take those patients as well. So the ideal scenario for external referral, so the patient needs to be interested, they sign a release. We talk about the 42 CFR. It's that's used more if you are specifically an addiction treatment facility. So in just general practice, in a primary care clinic and a family medicine clinic, you need to follow your HIPAA guidelines, but you don't necessarily have to get into the 42 CFR. And again, if there's questions on that, we can talk about that. So I talked about this a little bit. If the patient's not interested in referral, can you use motivational interviewing? Can you meet them where they are? Can you maybe find out, have they had, a bad experience in the past with that? Maybe it's a transportation thing. I have a lot of patients who struggle with transportation. So could they be set up via virtual visits instead? Just kind of seeing what they need and what they're willing to do. Again, I talked about this already, that the counseling services are not required, but they're a nice thing for a lot of patients to be able to engage in. And I'll have to say, on a, from a personal or, anecdotal perspective, I suppose, I have a lot easier time. My patients that have struggle with different addictions are much more willing to engage in counseling and therapy than most of my other patients in my clinic. So it's actually sort of refreshing. Developing your individualized treatment plans. I think it is really nice if you have support groups in your community. So whether that's Celebrate Recovery, Smart Recovery, AA, NA, those are fantastic for patients to engage with. If there's peer counselors or other folks with lived experience that can also engage your patient, that's useful for them. Okay, so mentorship, I talked a little bit about the Illinois helpline already. The Rush Fellowship team, and I'm going to put a link in the chat. The Project Echo, there is another Echo starting in May through Carl. It's phenomenal. If you have interest in time to do this, you get a bunch of CME, you get a stipend to do it, and it takes up an hour of your lunch every week for 6 months. It's a phenomenal thing to do. PCSS, probably a lot of you have used that to get your data waiver. So that is out there as well. This is the mentorship form that I talked about with the Illinois helpline. Here is the Carl and Rush Treatment Fellowship Echo. These are just really, really great programs. If you are interested in that, please, or if you have questions, let me know. And these are my references. And that was sort of a whirlwind look. I would be happy to answer questions.
I'm not seeing any questions as of now. If anybody would like to use the Q&A feature at the bottom to put your question in, we would be happy to get that to Dr. Austman for her to answer. Phyllis Ware asked if the slides will be available. Is that possible to send those out, or is that?
Sure.
Yes? Okay, yeah, we can get those sent out to you. Are there any other questions? It looks like Brent has a question.
Yeah, go
Go
ahead.
ahead and try again, Brent.
Okay, I was wondering, in your practice, how, and forgive me if you said this already, how long does it usually take for the patient, for a new patient coming in, to actually get the medicines in hand?
So are you asking about like availability at the pharmacy
No, no,
or?
no, like the
Okay.
process, for the process. Do they typically, does the script typically get to the pharmacy how quickly? For someone being for a new induction?
Yeah. So, I have patients call in, they always call in at 4:30 on Friday, right? They don't want to use anymore. They're done. They're in withdrawal. What can they do? And I try to get them in either the same day, or I may do a visit um, over the phone or via telehealth if they have access to video, and I send it that day. So the prescriptions are electronic and I send it right away. And then we try to see them within 2 to 3 days or soon, whatever the patient needs. I really, if the patient is ready for treatment, I try to do that as quickly as possible.
Okay. Do you mind a second question?
No, please.
Do you often hear from your patients about people not being able to do follow-up visits due to barriers of distance or poverty or transportation? And what do you do in those situations?
So all of the above, all of the above. And again, I treat like probably 4 to 5 counties. I mean, it's a wide geographic area, and a lot of patients have transportation issues. So quite a few insurances we can schedule rides, and they will pick the insurance will arrange for the patient to be picked up. Though we've had some struggle with that in that the dispatchers are telling the the drivers what they're picking the patient up for, and then our patients don't get picked up. So but that is an option out there. The other thing, I try to do as much telehealth as I can with those patients if they're struggling with transportation, and then getting them into the office. If I at the beginning, I try to get them in once a week or once every other week, just so I can kind of follow their drug screens for a minute or two. And after that, it's just patient dependent on how often I make them come into the office. When I did, if you're in an area where you could maybe you can do it all virtually, and you can just send um, an order to a lab. Like if you have a LabCorp request, if there's a LabCorp request close to the patient, or maybe there's a hospital where you could just send an order for a urine drug screen, if you want to be able to document that. So that's another option that you have. But you're right, there's so many people that have barriers to coming in, especially frequently.
Thank you so much.
Yeah.
All right, do we have any other questions for Dr. Austman? It looks like we have a few questions regarding the X waiver application, and I will get to more information on that shortly, but I want to give plenty of time for Dr. Kate Austman to answer any questions. Okay, thank you so much, Dr. Austman, for your time and providing your valuable expertise as it pertains to implementing medication-assisted recovery services. For our attendees, as always, thank you for your attendance. Let me turn my camera back on here. As mentioned in the beginning of the presentation, SIU School of Medicine is offering a grant. That grant is available to 10 healthcare organizations to implement MAR services between the months of August 2021 and April of 2022. I'm going to share my screen. A representative for the organization will need to fill out the application. I will post a link to the application in the chat, and you can also use your phone to scan the QR code that is on the photo here. If you have any questions, you can also go ahead and put those in the chat, and I will answer them. I know that we had a few. I can't see. There we go. So some of the questions, we had a question regarding providers completing the X waiver and if they would be eligible for the education and funding. And all providers who complete the X waiver training between August of 2021 and April of 2022 are eligible for $1,000 for the individual provider or prescriber. If they begin implementing MAR services between the same dates, August 2021 and April of 2022, they are eligible for an additional $1,000. So the prescriber could receive $1,000 or up to $2,000, depending on what is completed within that time frame. If the healthcare organization completes the application and begins providing the MAR services between August 2021 and April 2022, they will be eligible for the $10,000 grant. Are there any other questions regarding the healthcare organization grant or the individual prescriber grant? If you have any questions, you can email me. I will also post my email in the chat, and I'm happy to discuss how your organization can apply for the $10,000 grant. In order to receive credit, please use the QR code that will be got my share. There will be a QR code on the slide shown, and that will be used. And the link will also be included in the chat, and that will be to receive your CEUs. Right, in the chat is my email. And the link to access the application. This concludes the presentation. Thank you.
This was an excellent presentation. Is Dr. Austman still on? Everyone's off.
I am.
Oh, okay. All right. This was really, really excellent and very good information.
Thank you. Yeah, and if you have anybody that has any more, if you get people with questions or whatever, I mean, just forward on my information. I'm happy to, and I'm happy to take questions and whatever.
Okay, fantastic. Oh, I don't see me. Do you see me? Oh,
I do. Yeah.
Oh, okay. I don't see me. So, okay. And you went through the Carl Health Echo, the fellowship?
I went through Rush's. So
okay.
Maybe 3 years ago.
Okay.
Actually, it's kind of what started me on down this whole thing. And then since then, Carl has sort of, they're doing the same thing.
Yeah.
Only they're trying to hit more of the rural.
Right.
Yeah.
Yeah.
I'm helping with both of those. So I've been senior fellows on both of those.
Oh, that's, yeah, I've really been working with them to recruit down here in this area. I know they weren't, they were really wanting to keep it at first to their kind of their region, but
oh yeah, no, I think they've opened that up.
Yeah, there's a lot of interest in this area. So I
Perfect,
believe
yeah.
a few of the SIH physicians have, well, we had people from SIH go to Rush. So,
okay.
But yeah, it's a fabulous program. So
yeah.
Anyway, thank you so much. And I will send